assessment kind of choreography. You know, I know we learned a lot of assessment choreographies last week, but there's kind of the, I guess, the most condensed version, and this is the one, frankly speaking, that in my practice I do the most often, and it's like the one that's, what do you call it, when you cut everything from the bone, the most expeditious, the most bared down. So first of all, I'm going to check, well, obviously, of course, you get a history, right? Patient comes in, I heard, so, you know, you get your history, and then you're going to do your exam, or that would include, you know, various things in terms of, you know, they're standing, they're seated, they're supine, they're prone. I usually end up with prone stuff because then that leads into this, you know, kind of palpatory exam, your orthopedic test, your muscle test, and all that kind of stuff. So I'm usually going to start out with evaluating the leg length. If the person is, you know, short enough and their legs really aren't hanging off, I'll ask them to scoot down a little bit. You know, if they're long enough, I don't have to. And then once I've made this evaluation, I have them scoot back up. So I'm going to evaluate their leg length. I could do the Deerfield if I feel like there's a variance in relationship to the position. I can pinch the Achilles tendon and then use pressure on it to see if either one of those two motions, you can scoot back up to shot, causes any kind of a sensitivity, which gives you, again, another kind of marker. And then typically I'm going to start, I'm going to palpate the full spine, well, starting from the thoracic, actually, looking again for kyphosis, scoliosis, lordosis, those kinds of things. You know, I get down to the lumbosacral region, I separate my hands, put each on the patient's lumbosacral region, feeling for the PSIS, and then I'm able to get my static evaluation for pelvic symmetry. I come up and get the crest, and then the trochanter, and I do my horizontal leveling thing. I get my information about that, and then usually, you know, then I'm going to do joint play. Again, remember, standing square to the person's body, basically like perpendicular. My cephalad hand is going on the PSIS full flat. My caudad hand is going on the sacrum, kind of like karate chop, but then it just folds over, so it kind of looks like it's doing that. But my pressure is coming from my shoulder ball, so I'm, you know, ilium sacrum, ilium sacrum, ilium sacrum. I just slide over to the other side, ilium sacrum, ilium sacrum, ilium sacrum. Again, feeling for mobility, joint play, and I go back and forth several times to kind of, you know, shake out any variants or artifacts, or a person might be guarding with the first amount of pressure that you apply. But after doing it 2 or 3 times, it usually declares itself, saying, aha, this is the side that's fixated or not. And then, you know, depending upon my full evaluation, I can come up and then do the things in the spine, getting, you know, comparable information for joint play. But so if we're not really focusing on that part of the spine, I'm not going to worry about that. It seemed like, in this case, that this ilium or this leg was short, and there were some indicators that indicated that this was the lesion side. Okay, so this is the side I'm going to correct. So I'm going to have the patient turn on their side. So quite often, you know, they can do that themselves. And I'm just going to have this. I don't bump into it. So things to consider. You know, you saw last week with the basic lumbosacral setup, right? The top leg comes up, bottom leg is relatively straight. Now, when you know that this correction is where the patient's going to, you know, you're going to force their rotation. So you want to make sure there's enough clearance. You can kind of see that right now, if I just did this, I just slammed her thigh at the edge of the table. That doesn't feel good. So to avoid that, I need to bring the patient to the edge. And in order to do that, what I do so I don't hurt myself, I'm going to reach around, grab the ASI, the underneath ASIS, this hand comes around, and I'm just going to ask the patient, scoot a little bit closer to the edge. So as they scoot, I'm able to be supported in doing that, so I get them where they need to be mechanically speaking, okay? And then I'm going to take the tabled arm. I like to grab at the distal humerus and the distal forearm and kind of give a tug. I mean, you can do it like this. I've seen some people kind of do it like that. The idea is you want to make the pull diffuse, so it's not like hurtful. Then this hand goes on the shoulder ball, this hand goes on the rib cage. I've seen some people just put their hands together. That's certainly okay. This is my preference. I've also seen some practitioners like to have the shoulders stacked, meaning they're more like this. That's not my preference. But in the world of manipulation, there are people that, you know, utilize that technique just so you can see some variances. And so now getting to what we did last week, I'm going to evaluate the motion of the sacroiliac joint in a side posture position, or also known as a side lying position, or also known as lay on your side. So if you get that question in a midterm exam or a final exam, and I say in a side lying position, this is it. All right, so the first thing I'm going to do, I'm going to use my fingers, typically my middle and my index, and I'm going to feel the mobility of the SI joint. So I'm going to find the PSIS, okay, and then I'm using the femur as my vector or lever to kind of make that mobilization, right? And then once I feel like, okay, that's where I feel like the most movement is, this is the position that I want the leg to be in. Now, typically speaking, SI is going to be 90 degrees or greater if you take this line is 180 degrees, and the head is 0 and the feet are 180. When we start to learn how to do the manipulation of the lumbosacral spine, it's either 90 degrees or less is going to give us the leverage and the position for the lumbar spine. Okay, so once I made that determination, like, okay, there it is, so I want to keep the leg there. So what I'm going to do is use this hand to come over and hold the leg in the position. And then, right now, I'm in an assessment stance. So I'm making an assessment. Now I'm going to translate to a therapeutic or to the lunge stance, which is, again, is the fencer's position to do the correction. So, because I don't want to lose the position of the leg, I can hold it in place, and then I'm going to bring around so my leg is like this. So you can see how the
your thigh is on your
my thigh is on, my lateral thigh is on her lateral thigh. Okay? And then my hand, so my pisiform or hypothenar area is going to go on the PSIS. And then you can see how my forearm is basically parallel to the femur. I'll see that. I mean, it's not in the same plane, but it's in the same line. And then when I make my correction, I can do, this is kind of more advanced, but, rocking, locking, and then dropping. So the idea is I want to keep my outside thigh on her thigh so that when I make my drop, which is a genuflection, I'm coming down, and her leg is relatively staying in the same plane, right? What some people do is they make their contact more on the tibia, and then when they make their thrust, they go down like that, and they push the femur into more flexion, and then you've lost your specificity or contact, okay? So for today, once we start, we're going to do this first. You get set up, you can do your evaluation. You just want to get used to doing that. So you can see as I'm doing the genuflection, and again, genuflection, most of you are Christian or Catholic probably know what that all means, right? It's like this. So which leg is going further towards the floor? My back one. So that's the movement that you're going to make, is to come down like this, right? So you want to be able to practice that so that, and then more importantly, it's the dynamic thrust or force of my lower extremity, my body doing this more than my upper extremity pushing, right? This is not as strong as this. So more power comes from this. So you can just practice that sense of bringing the leg into that rotation. Because what you're trying to accomplish by doing the body drop, which in the chiropractic profession, the lumbosacral region is affectionately called the $1 million roll. Because the chiro profession has made $1 million off of it. Perhaps an individual practitioner may have made $1 million off of it, but that's the idea. So you want to be able to learn how to control how you put your pressure on the femur. So I'm just going to demonstrate it on the other side, so I stretch out equally, and you over here can see it. So again, the patient turns on their side, bring your top leg up, straighten your lower leg, scoot a little bit closer to this edge, please. So
you just ask the patient to scoot over.
Scoot to this edge.
But then you help them.
You did, yes.
Because
I'm doing it. Did you see it?
Yeah, I did.
All right.
You couldn't just say, could you scoot over?
But then maybe she's not going to come far enough. Or maybe she's going to come too far.
Okay.
And I'm not going to do this myself. Because then, I'd be jacked up. So I ask the patient to do it. Now you typically say, I don't usually say scoot towards me. Because it's kind of pelvis to pelvis. So you just want to avoid that image. So just scoot to this edge. Again, it's kind of creating it more professional or, whatever, that way. And so if they're doing the movement, then I don't have to, but I'm guiding them so they don't go too far or they don't go not far enough. Okay? So then again, get the patient set up, find the PSIS, There's the movement. Okay, that's where it needs to be. Stabilize, place my position, come into the thrust position, and then again it's like, so you can see how she's rotating, right? I'm not really putting any thrust into this. This is just what you can practice today. Yes, I can make that happen. You can create that rotation, okay? All right. Let's partner up and